Hello and welcome to our new topic about a group of very useful drugs. We will explore everything about drugs used to alleviate seizure disorders, their clinical applications, and adverse effects. These drugs carry significant risks, making a deep understanding essential for all clinicians. So, let's start. The learning objectives are shown. By the end of this lecture, you should be able to classify anti-epileptic drugs, describe their mechanisms of action, selectivity, adverse effects, and pharmacokinetic properties, and apply this knowledge to clinical scenarios. A seizure is a single, transient episode of abnormal electrical activity in the brain and may occur due to many reversible causes. Epilepsy, however, is defined as a chronic neurological disorder characterized by two or more unprovoked seizures. It is important to remember that having a seizure does not mean a patient has epilepsy. This slide highlights the modern classification of epilepsy, which is clinically important because drug choice depends heavily on seizure type. Correct classification helps us avoid inappropriate drugs that may worsen seizures. The overall therapeutic goal of anti-epileptic drugs is to shift the balance in favor of inhibition. This is achieved either by suppressing neuronal excitation or by enhancing inhibitory neurotransmission, or both. Let's see how it happens. The neuronal excitation is due to depolarizing ionic currents, such as sodium or calcium, and excitatory chemical mediators like glutamate. Sodium channel blockers stabilize inactive voltage-gated sodium channels and suppress high-frequency neuronal firing. Calcium channel blockers, especially T-type calcium channel blockers, are essential for absence seizures. Some drugs also inhibit glutamatergic transmission, which is particularly useful in refractory epilepsy. Similarly, the most important inhibitory neurotransmitter is gamma-aminobutyric acid or GABA, which acts by increasing inward chloride ion transport leading to intraneuronal hyperpolarization. Drugs, such as benzodiazepines and others, enhance GABA-mediated inhibitory neurotransmission either by increasing GABA action at chloride channels or by increasing the availability of GABA through reduced reuptake or metabolism. Too many mechanisms, right? Let's quickly summarize it before exploring further. Watch as this diagram integrates presynaptic and postsynaptic actions of anti-epileptic drugs. Now, let's see which drugs to consider according to the seizures and epilepsy. This slide reflects current NICE clinical guidance. First-line drugs are followed by additional drugs if needed, with usual preference as shown by the columns. The drugs with colored names are covered in this lecture. Note that certain drugs have broader spectrum and more commonly used than others, and some drugs which were main drugs in the past, such as phenytoin or carbamazepine, are now kept as adjunct drugs because we have better and safer drugs available. It is important to note that some drugs may exacerbate certain seizure types, emphasizing again the importance of correct seizure classification. In the next few slides we will explore individual drugs which are used generally, including first-line drugs and important adjunctively used ones. We will start our discussion with valproic acid derivative sodium valproate. It is a broad-spectrum anti-epileptic drug and also functions as a mood stabilizer. It blocks sodium and T-type calcium channels and enhances GABAergic transmission. Although effective, its use is limited by hepatotoxicity and significant teratogenic risk. Lamotrigine is another broad-spectrum drug that blocks sodium and T-type calcium channels and suppresses glutamate release. It is generally well tolerated but must be titrated slowly to reduce the risk of serious skin reactions. Levetiracetam acts by binding to synaptic vesicle protein SV2A, reducing neurotransmitter release. It is well tolerated, has minimal drug interactions, and is eliminated renally, making it particularly useful in many patient groups. Topiramate has multiple mechanisms, including sodium and calcium channel blockade, facilitation of GABA transmission, and inhibition of AMPA receptors. Its broad spectrum makes it useful, but cognitive slowing can limit use. Carbamazepine is a narrow-spectrum sodium channel blocker widely used in focal seizures. It induces hepatic enzymes and undergoes autoinduction, which has important implications for dosing and drug interactions. Phenytoin is a sodium channel blocker with unique pharmacokinetics. It may exhibit zero-order kinetics even at intermediate doses, meaning any small dose increases can cause toxicity. The more peculiar adverse effects are gingival hyperplasia or gum swelling and abnormal hair growth or hirsutism. Ethosuximide is highly selective for absence seizures due to its blockade of low-voltage activated T-type calcium channel blocker in thalamocortical neurons. These channels are responsible for the classic EEG waves seen in absence seizures. Gastrointestinal upset is common, but serious toxicity is rare. It has a very slow absorption as well as elimination rate. Benzodiazepines and barbiturates are mainly used for acute seizure control and as adjuncts. Benzodiazepines have a wide margin of safety, whereas barbiturates induce hepatic enzymes and cause significant sedation. More detail about this group is given under a separate lecture on sedative hypnotics and can be explored there. Epilepsy has potentially hazardous outcomes in pregnancy, both for the mother and the baby as listed. Treatment with anti-epileptic drugs may reduce those hazards listed before, but increase the likelihood of another set of adverse effects which are drug-induced. However, the drug-induced risk is still lower than untreated. With careful planning, such risks may be further avoided. The anti-epileptic drugs themselves carry varying degrees of risk. No drug is absolutely safe, but lamotrigine and levetiracetam are relatively safer, while valproate carries the highest risk. Fetal malformations have been documented with various anti-epileptic drugs, such as fetal Hydantoin syndrome seen with phenytoin. Apart from that, there are long-term detrimental effects seen also. So, how to increase the chances of reducing drug hazards in pregnancy? Best practice is monotherapy started at the lowest effective dose with appropriate vitamin supplementation where needed. The long-term management of epilepsy requires accurate seizure classification, gradual dose titration, preference for monotherapy, monitoring for drug interactions, and regular reassessment of treatment necessity. This approach maximizes the chances of a good therapeutic control of epilepsy as well as avoid epileptic emergencies, such as status epilepticus. Status epilepticus is a life-threatening emergency defined as continuous seizure activity lasting 5 minutes or more. Prompt treatment is essential to prevent permanent neuronal damage. Here is a typical stepwise algorithm to treat status epilepticus. We usually start with a benzodiazepine and aim for more profound suppression as shown, depending upon the severity and control of seizures as necessary, to the extent of even general anesthesia in severe refractory cases. In summary, anti-epileptic drugs work by reducing neuronal excitability through multiple mechanisms. Correct drug selection depends on seizure type, patient factors, and safety considerations. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!